Yeah, you can't.
Welcome everyone,
so
and
nice.
welcome back from
Wait,
lunch
right,
break. Hopefully you had a lot of interesting conversations with all the attendees here today and speakers and networking people as well. So welcome back, and we have a lovely session 4, with two great presenters. So we have Cecily Henry and Professor Sophie Park. And they will be talking about engaging with patients and involving their voices in research and education. So I will not talk very long, just a reminder that we have Slido. So any questions during a session, please do post your questions, and we'll have some time to answer those at the end of the session. And without any further ado, and please welcome Sophie and Cecily.
Thank you. Thank you. So should we just introduce ourselves? So I'm Sophie, I'm Professor of Primary Care and Clinical Education at Oxford and a GP. And Cecily?
Yeah, and I'm Cecily Henry, and I'm a well, I call myself a public partner in research. There's so many different names going around: public contributor, reviewer, and so forth. I call myself a public partner in research. Have been doing so since about 2018 on various projects, and yeah, looking forward to sharing with you.
We're both co-leads for the NHR Incubator for Clinical Education Research PPI group, which we'll come on to in the talk. Are you willing to showing our slides? Marvellous. Can you all see that? Great. Okay. So we're going to touch on 4 different areas in the next 20 minutes. One is around what PPI is, and Cecily's already alluded to, there's lots of different terminology around that, and it can mean different things to different people. We're going to talk a little bit about PPI partnership and what it can bring both to those who are contributing to the research, but also to academics doing research. A few tips around how to get started and the sorts of things you might need to think about. And then our final slide is just to highlight the incubator and work that we're doing together to support PPI work in clinical education research more broadly. So do feel free to get in touch with us afterwards. And we're going to kind of swap throughout. So we'll kind of go between. So the first thing is just to think about what PPI is. So who here has worked with PPI before? Great. Anyone online? Any hands up?
You can't see hands up.
Can't see hands up online.
Oh, what?
Okay.
1. Okay, great. Excellent. So there's a myriad of definitions, and some use the term PPI to mean experiential knowledge in general. So kind of the human dimension. So they might mean professionals, stakeholders, public. Others tend to use PPI specifically to mean patients or users. So in the literature, you'll come across both. Some will talk about students, learners, and teachers as PPI, and in other papers, they'll talk about them as stakeholders. So we're today going to focus mainly on patients in clinical education research, just because of time constraints. But lots of our published work uses both. Both as patient and student advisory work, but also with students and patients as co-applicants in our research projects. So do have a look at those. And in some work, PPI is used as a verb to mean the process of involving others. And in other work, it's used as a noun referring to someone who is in a PPI role. So we'll probably move interchangeably between the two. So within clinical education research, there are multiple different perspectives, and we heard before lunch about some of those perspectives in relation to parliamentary work, but involved people or end users in clinical education research can be really varied. So we might have learners, patients, assessors, institution representatives, governance institutions. There are all sorts of different dimensions that we might need to think about. And there can also actually be some ambiguity about what do we mean by clinical education research. And certainly when we're approaching PPI to be part of work, it's really important that we're clear about what we mean by that. So it's a really broad field, isn't it? From undergraduate, postgraduate, professional learning. And there might be different points of balance between classroom teaching and service-based learning. And some might be direct or explicit study of student learning, and some might be much more interlocking with clinical practice. So, for example, we heard earlier about workforce or learning in the clinical workplace, exploring what knowledge from clinical practice students need to know. All of these might be categorized as clinical education research. So in clinical education, patients might be involved in a clinical setting or in a campus session, and people might be a current patient, a past patient, or even a simulated patient like Cecily does. And professionals might also bring their own experience as members of healthcare users, carers, relatives, patients. So some public members, when you approach them to get involved, might not know what clinical education research is at all, and that might be okay, but it's really important to bear in mind what experience that person might bring when you're thinking about asking if they'd be willing to work with you on a particular project.
Yeah, so in terms of embedding PPI throughout the whole research cycle, it's important to realise that it's important from the start, really, or even from before, getting patients and the public to help with thinking about ideas in terms of what's relevant to us as patients and members of the public, because there's no point undertaking research which just doesn't sit or fall well or just resonate with members of the public. In terms of clarifying the research question, I mean, I personally have been involved in different areas, you know, whether it's shaping the idea, helping to write, say, like patient information leaflets or giving advice around information leaflets, disseminating information. So it's really important just for meaningful PPI, for it to be really embedded throughout the research cycle. And I think one of the analogies I use in terms of having members and members of the public on your, well, kind of research team, as it were, that's kind of what it is, kind of like an extended team. I use like a mountaintop analogy. So, you know, as a researcher, you might be coming in, you've got your own specialism in terms of your field. It might be midwifery, physiotherapy, medicine. So you're coming in with your own kind of eyes and ears from that perspective. But and then you might have a team of people around you. You might think, say, if you are in midwifery, you might think, okay, I'd like to have somebody who's, you know, maybe a GP, for example, or somebody who will look more in terms of the statistics. So you'll be gathering up your kind of expertise and teams around you to, again, see a different insight, but you're all still maybe from an academic point of view. So yeah, you see the people on the mountain, they're standing facing the same way, but they can probably see slightly different areas. But with patients and the public, you get a wider perspective. You've got that really nice holistic panoramic view of what's going on. So from that patient's point of view, which can be sometimes quite different, and especially when we're thinking about underserved communities as well. It's, you know, you might be working on a study about homelessness, for example. So really having people who have understanding in terms of homelessness would be ideal and amazing.
So Cecily's going to talk in a minute about the UK standards for patient involvement, which you were involved in writing. No, you weren't. Okay. But we've just drawn up a few key tips to getting started. So our first one, I think, is probably the most important, around relationships. So we really need to focus on building and sustaining respectful relationships together. Our next one is around pace. So really pace yourself and start small. And we'll come on to talking about the time that it can take to really do PPI well and the resources that you might need. The next one is around recognising that not everything that emerges in a conversation between you and PPI colleagues will be possible to include in this particular project. And it's really important that everybody understands that. It's not that an idea has been rejected or forgotten, it's just there is a particular scope or boundary to any project. So be realistic and honest about the scope and what resources are available to support the PPI work that you plan to do this time. Don't be afraid to get started early. As Cecily's already said, this is the most meaningful point in the conversation, to actually have a conversation with PPI. And if you're going to do anything at any point, have that conversation right at the beginning. That said, that's often the most difficult time to get funding to support that PPI conversation, because you haven't yet got the grant. And yes, it's so important to actually informing the application and the research questions. And then our final one is around feedback. So really build in feedback into the exchanges that you're having together, so that you can reflect on what is and is not working throughout the process. So this next slide is about values and the paramount importance of sharing with PPI partners that they are valued. And you can't assume that that's obvious unless you actually demonstrate some behaviours that show people that they are valued. So, for example, you might plan regular feedback conversations, or have conversations about the clarity of processes around payment and what is wanted from a project. And then you need to ensure that your PPI colleagues feel there is a genuine partnership. And I think there is an emancipatory potential for both academics and patients. It can feel terrifying to take your research question to a PPI group, knowing that it might get completely changed and potentially go in a different direction. That can make you feel very vulnerable, but it's a good thing. And the same for PPI colleagues. It can feel terrifying if you don't actually understand what it is that's wanted, or who you're supposed to be in that context, and what identities you're expected to hold. So be aware of that, but embrace it. And then recruit carefully so that you can use both the known demands of a project, but also have space for some of the unknown, so that you can actually learn together and grow together in unexpected ways. And then the final one is around ongoing process. So keep it fresh, keep involving new members, as well as developing expertise within the team. So this last slide, before Cecily is going to talk for a little while, is around the stuff that's happening underneath the iceberg. So I think it's probably the easiest part of the conversation is to justify the moral and social imperative for partnership with patients. I think most people agree it's a good thing to have that knowledge exchange. But by definition, you are trying to change the boundaries around how we all work and how institutions work. And I think both of us, the key message is it is not easy, and actually working at the interface of those boundaries and trying to overcome a lot of the institutional norms and traditions is probably the hardest part of the process. So stuff that we put underneath the iceberg that is essential to actually make the moral and social possible sound very mundane, but they're so important. Mm-hmm. So things like negotiating payment and salary, and knowing whether the particular PPI that you're working with might want to be paid, or whether that's going to affect their benefits. Being clear around expectations and timelines of payment processes and preparation, thinking about expectation for how often you're going to meet, and available time for training and debrief time. These all can take a lot of time, and if you're the PPI co-lead, that's really important for you to negotiate in advance. And then institutional governance. So just an example, Cecily and I were preparing these slides. Cecily had access to Canva, I had access to PowerPoint and Keynote. We couldn't actually, we didn't have a common language through which to do the slides. So we could easily have done 2 10-minute presentations using different slides, but we didn't. We persisted and we've done it. But those kind of minor things actually can prove really challenging. Or if you're collaborating on a document, one person's got access to Google Docs, another hasn't. Those kind of things. Thinking about email sharing, physical access to buildings as co-workers, and helping each other to feel valued, and recognizing that you're going to have to balance those power relations and dynamics.
Mm-hmm. Yeah, definitely. So then, thinking in terms of patients and carers and members of the public, in terms of medical education, clinical education research, which is obviously the content will be different to clinical research. Why would patients want to get involved? Because a lot of times they speak in terms of, oh, it's so far removed from patient benefit. But if I can just share a little bit about my journey, for me as a Black female, I've had bad experiences in terms of the healthcare service, been left feeling in most negative ways, also key messages about health. I end up feeling like, oh my gosh, am I going to die at a premature age? So it's just led me to this fear. And in terms of, I don't really particularly want to use health services, but I know in terms of having 2 children and them having their own health conditions, I need to get over that. I need to get over my fear. I don't want my fear going over to my children. So I felt like in terms of myself, should I go to kind of Solutionville or Problemville? And I felt that, okay, in terms of me not doing anything, I'd be part of the problem still. So for me, getting involved in patient and public involvement and getting involved in understanding how the clinical education system works as well, it's helping me to kind of gain back trust and also make a difference with my own voice. So here's just a bit of a timeline in terms of my involvement. So in terms of just different areas, in terms of simulated patient, but also patient and public involvement. So that's really helping me in terms of building up that trust and making a difference. So I've got 3 main observations just quickly in terms of myself from a public contributor perspective. In terms of PPI and clinical education, for me personally, I don't really see much difference in the process between clinical education research and clinical research. The process is the same. You get, you know, like the diagram shows, and also this table, which is medical education in particular, but could also relate to kind of clinical education. There's so many different ways that we can be embedded in the research process, in terms of analysing data, planning data collection, so many different ways. In terms of, so for me, research is research, really. It's more the content is going to be different, just like the AI content will be different. Number 2, in terms of embedding the UK standards for public involvement, it's really important when we think about, say, the outcome, which is related to kind of what can PPI partnership bring to clinical education research. And when we think of that, this helps to bring meaning. So there's projects that can say, oh yeah, we've got PPI, but is it meaningful? You know, some public members feel as though, well, we've not really been involved. It's just a tick box. But having something like the UK standards for public involvement as a framework, thinking about communications, for example, and how we're going to work together, adds a more robust strategy and foundation to your PPI strategy. And then lastly, in terms of developing an effective and adequately resourced PPI lead, that will really help in terms of how you get started. NIHR funding stipulates that you have to have a PPI lead, but it's really important that the PPI lead does have the amount of time and resource, you know, even if it's training resource, time to be able to undertake that role. I mean, I personally have more compassion now because I was involved in as a public co-applicant, and the actual study didn't understand that PPI leads and public co-applicants are different, and they conflated it. So in the end, I ended up being a PPI lead because there was nobody else to. And but from my perspective, I understood how difficult it is, because I was having to kind of mediate between the research team and also go find out things from different departments, such as finance, and also just so little time it takes chasing up on payments and so forth. So it's really important to have that space and time. And if you can, maybe have a public co-applicant helping to support that process, bringing their insight.
We can't see the QR code. I'm just going to move Drew, I'm going to move you very slightly, if that's all right, into the middle of the screen. No, you can't see what. Anyway, at least you can see the QR code. But this is just an example as some reflective prompts that we developed as part of doing a realist evidence synthesis with PPI. We co-developed these together. It wasn't with Cecily, it was with some other PPI colleagues. But thinking about what do the research team need to think about in terms of working with PPI, and then what might PPI colleagues who are thinking of working on a realist review need to consider when they're engaging in the process. So that's just an example. There's lots of different resources out there, but that one's particularly relevant to clinical education research. And then finally, I'll move through back again. Hang on, here you go. Whee. This is this is to highlight our work together in the incubator with Gillian and other colleagues. And we're leading the PPI element of that, which is new to the second kind of iteration of the incubator. And there are two key elements to this. One is around the community of practice for PPI and expert by experience. So we're working together to get to a point where we have a collective of PPI people who are interested in the topic, trained, growing their expertise and experience, and able to have those connections and conversations with people who want to work in clinical education. And we're also having ongoing conversations with the RSS, which has been fantastic, around connecting with other groups and their expertise and how we might apply that in clinical education research. And then the second kind of interlocking community is around academic colleagues who want to work with PPI, and we're all learning together. It's a really new area, as I say, with the institutional boundaries. And so connecting people who are interested in that so that we can grow together. Thank you very much.
Thank you so much. Hope you hear me. Right? I think so. Yes, thank you very much for a great presentation and sharing your experiences and all the great things you do. A lot to learn, and we have a few questions now, and maybe the rest would be for the end, if that's okay. So one of the first questions which came in was, is there any high quality empirical evidence that patient or public involvement leads to better research with more impact?
Oh, interesting question. Well, the first element of that is how you measure that, isn't it? So how do you judge that something is better quality or is having a better impact? There is lots of research now that shows that PPI connections within research really broaden and expand what we look at within our research, how it changes the focus of a particular research question, or might then help with dissemination and engagement beyond the kind of lifespan of a particular project. So it depends what you mean by good quality, but I think we both argue that good quality does mean that it is more socially accountable, and it hopefully is having a broader reach than it might otherwise.
And from my perspective as well, I've not seen any evidence or data, but I know being within groups and advisory groups, for example, the amount of times researchers have been like, hadn't thought of that. And as a member of the public, just like, well, for us, it's just like, well, that's a kind of everyday thing. So I see it from that perspective, and you know, I feel researchers are really grateful for it, actually.
I think one of the challenges is that kind of, you can't predetermine those conversations.
No.
And so building into the project a bit of flexibility, which I think probably people that work in qualitative research are a bit more used to, that slight kind of unsettled space. But if you're used to working quantitative research where everything is sort of pre-planned, it can feel a bit unnerving. So which is why it's so important to have those conversations right at the beginning.
I guess some of the questions were actually, how do you have that involvement when you have really statistically heavy UK-Med based project? So any thoughts? And quite a few questions about doctoral research fellowship. So any kind of examples maybe of good practices from your experiences, what worked quite well for such involvement?
So thinking about the question about kind of quite statistical, I'm involved in a project around mathematical modelling in terms of vaccinations. So for that, it was they didn't know how to get PPI, and actually they've come at it from a perspective, it's actually nobody knows what's going on, nobody knows what to do, and we're having these kind of talks and almost like from a researcher point of view and patient point of view, it's that ongoing discussion and collaboration and really shaping. And it's not, it's a really safe environment because everybody knows actually we don't know what's coming next, but it's a really nice kind of space to be able to explore together. And it's still kind of ongoing, we're still involved, and some of us as patients are like, it feels so beyond us, but then we're helping the researchers to help us to understand, if that makes sense. So it's that ongoing dialogue. Yeah, it's that dialogue that's really important.
So another example is a project I recently did with Pete Bauer that was looking at research activity of general practices nationally. So that was mixed methods. Most of the project was quantitative, small amount was qualitative. And so we had a really large PPI group that we would meet with regularly as part of that. And those PPI were really helping us to target which questions we were going to ask and then reflect on what data we did have, what we didn't have, how we were going to manage that, and then earmarked certain areas that we were going to look at for more explanatory work in the qualitative arm. So they fed in throughout the process, and then there were co-ops on some of the writing as well. Yeah, so I mean, there's loads of different ways you can, and a lot of doctoral applications do work with PPI around what does my research question sound like, you know, are there different ways that I should be thinking about that? And I think with clinical education research, it's not just about having conversations with patients, it might also include learners, stakeholders, other people, however you might call them.
Thank you very much.
Thank
Thank
you.
you for. So we have a next. Just stop recording. We'll have another session in